Hi, everybody. I'd like to welcome everybody to this webinar this afternoon. We're delighted to have Dr. Camilla Lindvall-Dalgan joining us, and she's a senior researcher at the Regional Department of Eating Disorders at Oslo University Hospital in Norway. But she's currently living in New York City, where she works as a visiting scholar, dividing her time between the Eating Disorder Research Unit at Columbia University Medical Center and at the Eating Disorders and Weight Program at the Icahn School of Medicine at Mount Sinai. She completed her PhD though in Oslo in 2013, which focused on the feasibility of cognitive remediation therapy for adolescents with anorexia nervosa. She's a member of the Eating Disorder Research Society and has published widely, including peer-reviewed journal articles and book chapters. And she's also the lead author on 2 published manuals for CRT for young people with eating disorders. She arranges CRT workshops worldwide and has taught clinical skills to diverse populations, including psychologists, medical practitioners, and allied mental health professionals. Her main professional interests lie within eating disorders treatment and assessment, with special interest in neuropsychology and diagnostic evaluations. So we're so thrilled to have somebody with Camilla's caliber here to present to us on CRT today. We're going to have Camilla talk to us for about 30 minutes. And then at that point, I'm going to take some questions and Camilla can answer them. By the way, my name is Alison Darcy. I did not introduce myself. I'm an instructor at Stanford School of Medicine. I have worked with CRT as well in adolescent populations with anorexia and with adults. And Camilla is also an old friend of mine. And I'm also the co-chair of the Electronic Media Committee for AED. So welcome, everybody. And now I'm just going to hand over to Camilla.
So, hi everyone, this is Camilla here. Thank you, Ali, for this introduction. Just want to start off by saying that I have made a presentation that's an hour long, and I was supposed to make a presentation that's 30 minutes. So I'm going to skip some of the slides or go through them a bit more quickly than I thought. I think you all should have handouts on my presentation, and if you don't, I can send this to you afterwards. My email address will be at the end of the presentation. So if there's something that you saw that I didn't go through, don't worry about it. I'll give you the full presentation afterwards. All right, so I'm going to start today by talking about cognitive remediation therapy for anorexia nervosa. And I would like to start off by thanking the AED for inviting me to do this webinar. I look forward to it. So Ali already walked you through a bit about my background, so I'm going to skip this slide. I just want to very shortly introduce you to the content of this presentation. I'm going to start talking about the introduction to CRT, so just a bit about the background. Then we're going to go into the implementation of CRT, so how do we actually use CRT with our patients. And if we have time at the end of the presentation, I'm going to talk to you a little about the research and the evidence base behind CRT for eating disorders. But let's start with the introduction. So what is actually cognitive remediation therapy for anorexia nervosa? Well, it is a relatively new treatment approach for this type of eating disorders. And for eating disorders, it was developed by Kate Chanturia and her colleagues at King's College in London, UK. The first paper that came out was a case study from Kate Chanturia and her group depicting cognitive remediation therapy for an adult female patient at their clinic. It's very short. It's a short, usually a 10-session long intervention that focuses on the process of thinking rather than the content. So we focus on the how rather than the what. And the aim is to increase cognitive and behavioral flexibility and to help our patients to achieve a balance between detailed and global information processing strategies, also known as central coherence. And how do we do this? Well, we try to engage our patients in metacognitive processes. So we try to help them to identify, understand, and challenge their own thought processes. And we ask them to explore alternative thinking styles, both in sessions and between sessions. And the ultimate goal in CRT is for the patient to be able to alter inefficient cognitions and behaviors in their everyday life. And continuing to talk a little bit about CRT, I want you to know there is actually quite a big difference between CRT and traditional treatments for anorexia nervosa. And in contrast to the treatment that is usually offered to patients with AN, like for the younger ones, family-based treatment, or for adolescents, CBTE, CRT aims neither to address nor directly to treat core eating disorder symptoms. And the focus is purely or primarily to spark curiosity with regards to our patients' thinking styles, without the burden of having to address emotional topics such as food, weight, or shape. That being said, CRT has and should always be delivered as an adjunctive treatment. CRT is not a standalone treatment for anorexia nervosa, so I want you to think of it as an additional treatment to treatment as usual, rather than an intervention designed to replace existing treatments. And this is important because we wouldn't want to deliver CRT as a standalone treatment for anorexia nervosa because it doesn't focus on core eating disorder symptomatology, and this is really important for this patient group. So CRT should be and has always been delivered as an addition to treatment as usual. And unless that changes dramatically in the near future, that's the way it should be done in the future as well. So why do we think that it's appropriate to deliver cognitive remediation therapy for anorexia nervosa? Well, during the last decades, there has been a substantial increase in studies investigating the impact of neuropsychology on both eating disorder etiology, its maintenance and recovery. And for anorexia nervosa, the focus has primarily been to kind of explore how weaknesses in cognitive flexibility and central coherence contribute to the development of the disorder, its perseverance, and the likelihood of recovery. And early clinical observations and neuropsychological studies in anorexia nervosa actually lay the groundwork for the development of CRT for this patient group. And it is an intervention that is specifically tailored to remedy weaknesses or information processing biases in these two domains, so in central coherence and cognitive flexibility. So moving on to cognitive functioning in anorexia nervosa, well, we know that in adults, the main finding from neuropsychological studies have revealed weaknesses in cognitive flexibility and in central coherence. And in the younger patients, so both in children and adolescents, we can see that rigidity and preoccupation with details, they're often observed and reported by clinicians, but it's limited in its empirical support. And recent research has actually reported mixed findings for these two domains, or impairment in these two domains in the younger patients with AN. So if we're going to focus on these two domains, because these are the two pillars of CRT, the cognitive flexibility one and the central coherence one, I want to talk to you a little bit about what they are and what they actually mean. So what is cognitive flexibility? Well, it's an important component of our executive functions. It has been described as a mental ability to switch between thinking about two different concepts and to think about multiple concepts simultaneously, so multitasking. And it allows for people to shift back and forth between different information units or mental sets and to multitask. So I'm going to give you an example of cognitive flexibility just to make it a little bit easier. So this webinar, for example, I'm going to use that as my example. So in this webinar, I'm watching the slides on my computer in front of me. Simultaneously, I'm speaking to you in English, and I'm actually doing some translation as well because I'm Swedish, but I've lived in Norway for about 20 years. So I'm doing some translations in my head. When I can't figure out the English words, I have to very swiftly translate it into English so that you understand what I'm saying. And at the same time, I'm actually watching my clock or my watch because I know that my part of this webinar, the ones that I'm talking to you about CRT, is only 30 minutes. So I have to keep an eye on the watch all the time as well to kind of to see that I don't, go over the time. When we talk about impaired or poor cognitive flexibility, that means that you will have difficulties in shifting or changing mental strategies. And this inflexibility can manifest as an ability to adapt to changing circumstances and in difficulties in overriding well-learned cognitive and behavioral patterns. So what does this look like in patients with AN? Well, in individuals with AN, it's suggested that poor cognitive flexibility leads to difficulties in changing thoughts and behaviors that perpetuate the eating disorders. So an inability to change unfavorable eating pattern or habits, in an ability or difficulties in stopping to body check, or actually some people who try to avoid mirrors to start looking at themselves in mirrors. And of course, the difficulties in stopping excessive exercise, for example. And challenges in these behaviors make it really difficult to achieve changes in therapy. So let's move on to our next concept, the concept of central coherence. So what is that? Well, central coherence refers to the tendency to process information in terms of the gestalt, the bigger picture, rather than in fine detail. And the ability to process information in this bigger picture or globally, it enables people to perceive themselves and their surroundings as a whole rather than separate or detached units. And it also allows for interpretation of details contextually, so it gives a fuller understanding of the integration of an overall relationship between details. So I'm going to give you another example just to make it a little more clear. So I've brought forth a puzzle here. So when you're to do a puzzle, you need to keep an eye on the details, because you have to look, at each and every little piece of the puzzle, so where it goes and what it looks like, in order to be able to put it in the bigger picture. So you have to be able to interpret all the little pieces, the details, contextually. And when you can do that, it kind of gives you a fuller understanding, and you will understand the integration of all these little pieces and how they fit together in the bigger picture. So what does impaired or poor central coherence look like? Well, when we talk about poor central coherence, we talk about a disrupted balance between detailed and global processing. So that is either a preoccupation with details or too little focus on details, or preoccupations with the bigger pictures, or too little focus on the bigger pictures. And either or, these will make it challenging for you in your everyday life. And when it comes to impaired or poor central coherence and anorexia nervosa, we know that neuropsychological studies in adult patients have yielded evidence of weaknesses in global processing, so weaknesses in seeing the bigger picture, but some has also reported superior attention to details. And we know that a disrupted balance between the global and local information processing results in an excessive preoccupation with details at the cost of the bigger picture in this patient group. So in terms of the illness and in relation to illness, we could see this preoccupation with detail as manifested in this pathological fixation with calorie, fat, and carbohydrate content, for example, and this preoccupation with weight gain and loss, body image, and detailed exercise routines and practices. And all these are features that perpetuate eating disorder psychopathology. So let's go back to talking a little bit about why we want to do cognitive remediation therapy for anorexia nervosa. Well, we've been talking about central coherence and impaired flexibility, and we know that patients with anorexia, they're often preoccupied with details at the cost of the bigger picture. And in addition, they're commonly reported as being rigid in terms of thoughts and behaviors perpetuating the eating disorder. So the aim of cognitive remediation therapy for anorexia nervosa is for the patient to identify their thinking styles. So are they thinking rigidly, or are they preoccupied with details? And we want them to understand why they think the way that they do. And we want them to try to challenge thinking styles that are not beneficial by exploring alternative ways of thinking. And ultimately, we want to try to help our patients to be able to alter inefficient cognitions and behaviors in their everyday life. So we've been talking a bit about the CRT focus, the decreasing of the rigidity and increasing flexibility, and to achieve the balance between local and global information processing. Let's move on. Let's look at the implementation of CRT. So we're going to look at how we help our patients to engage in metacognitive processes, how we help them to identify, understand, and challenge their thinking, how we help them to explore alternative thinking styles, and how we help them to focus on how they think rather than what they're thinking about. So how do we do CRT with our patients? Well, we present the patients with cognitive challenges, which can be games or puzzles or tasks. And then we use a particular set of questions to encourage our patients to engage in metacognitive processes. And that means to reflect on how they think whilst they're working on a task or after, or sometimes both. Then we ask the patients to identify their thought processes, to evaluate advantages and disadvantages with these, and to explore alternative ways of thinking. And patients are then encouraged to relate his or her thinking styles to real-life situations and to subsequently explore the pros and cons of these in everyday life. So what materials do we use when we work with our patients? Well, there are a couple of different manuals out there. This cognitive remediation therapy resource pack was developed by me and Betteke van Noord and Brian Lask at my department in Oslo. It's freely available online on our website or at my ResearchGate profile. It was developed for children and adolescents, but it can also be used with adults. And it provides an overview and background for CRT for AN, plus all the information you need to start doing CRT with your patients. So this is the one that I've been using in my CRT work with the younger patients. There's also a lot of material that has been developed by Kate Chanturia and her group at King's College. And she has a cognitive remediation manual for adults, one for group adolescent therapy, and she's working on a self-help guide for use with carers. So what kind of tasks do we use when we try to help our patients to become aware of their thinking styles and to challenge those thinking styles that are not working efficiently? Well, we use both paper and pencil tasks and board games. This is a typical task that we often use to work on set shifting. It's actually taken from the traditional neuropsychological task called Stroop. So this is one of the paper and pencil tasks that we're using. Another one is this called geometric figures. It's really good at getting your patient to reflect on finer details or the bigger picture. So we ask our patients to describe geometric figures to us and try to figure out if they start describing these figures by using the larger elements or the smaller elements. This is another task called the illusions, which is really good in trying to figure out how your patient think in terms of flexibility, but as well as in terms of central coherence, because this picture here is an old lady, but it's also a little guy playing his banjo. So are our patients able to identify both these pictures, and are they able to swift or to kind of swap between them? The board games that we're using, the use of board games was actually introduced in our CRT resource pack that we published a few years ago. And most of them have been gathered from a company called ThinkFun. So this is the Rush Hour, this is the Connect 4, and this is something called Bananagrams. And the board games are really useful in kind of playing together with your patients. And you get a really kind of nice atmosphere in therapy when you play together. And the guiding questions. We shouldn't forget the guiding questions, because those are the part of the treatment that actually encourage your patients to think about their thinking styles. So this kind of metacognitive component helps our patients to explore their cognitive styles. And we use a small variation of a predetermined set of questions during CRT. And the reflection process is, of course, dependent on what kind of materials you use and on your patient. And sometimes it's useful to use the questions while the patient is working on a task, and sometimes after. These are the guiding questions. They are also available in our CRT resource pack, which I talked about earlier, so I'm not going to go through all of them. But you can find all the questions in there, and these are really important questions to use with your patients in trying to get them to to reflect on their own thinking styles. The tryouts. The tryouts are little homework tasks, and we encourage our patients to relate his or her thinking style to real-life events and to subsequently explore the pros and cons of using these strategies in everyday life. And they're introduced once the patients feel ready for it, and they're designed to help our patients to use the knowledge acquired during CRT and to experiment with this knowledge outside therapy context. And they're not supposed to elicit strong emotional reactions, so we usually don't ask our patients to do these tryouts in relation to food or weight or shape, unless the patient wants to, of course. I've listed a couple of examples of these kinds of tryouts. For example, wear a different color nail polish, or wear different colors on all your fingers. If your patient has a piece of clothing or a type of clothing that he or she wears daily, try to wear something else for one day. Number 3, choose a new route when visiting a friend or going to school or work. So we've talked about the tryouts, we talked about the content, the tasks, and the guiding questions. So let's talk just briefly about the CRT delivery. In what way can you deliver CRT? When we look at ages, it's actually appropriate for patients at all ages. It has been developed and used or implemented for children, for adolescents, and for adults. It was originally developed for adults with AN, and that's where all the kind of background material comes from, the neuropsychological evidence. But it's proven to be actually quite useful for younger patients as well. In terms of format, CRT has been delivered individually, in group, and in families. And all these have their own pros and cons. When you do it individually, you'll be able to to use tasks that are specifically tailored to each patient and to design tryouts that are specific to each patient. When you do CRT in groups, patients can learn from each other, and it might be quite nice to actually experience that other people are having the same thinking styles as yourself. And in families, you will be amazed of how many patients and parents that actually realize that they have the same thinking styles, although they might not think. CRT has also been delivered on inpatient units and on outpatient units, and that works really well as well. My feasibility trial mixed patients from both type of units, and that worked really well. In terms of intensity, it turned out for the patient group that I was working with that 2 times a week was more appropriate for the inpatients, which we had access to all the time, and once a week was more appropriate for outpatients. But there are no rules, or there are no set guidelines for how often you want to do this. So you'll have to kind of consider your resources, your patient's needs, and how much time they have actually, and if they're an inpatient or an outpatient. So I see now that we actually have a few minutes left to go through the CRT research. So I'm going to do this very, very briefly. So is CRT an evidence-based practice? Well, if we're going to talk about CRT as an evidence-based practice, we want to look at the definition. And here it says the integration of clinical expertise, patient values, and the best research evidence into the decision-making process for the patient care. And clinical expertise refers to the clinician's accumulated experience, education, and clinical skills, and the patient brings to the encounter his or her own personal preferences and unique concerns, expectations, and values. And the best research evidence is usually found in clinically relevant research that has been conducted using sound methodology. So if we look at these 3 pillars, we know that there are many skilled clinicians out there having had proper CRT training and who are doing CRT at this point in time. So a lot of them has been trained by Kay Chanturia in London, and a lot of them has been trained by me. We also know that patients like CRT and that attrition is low. So a lot of the patients who begin CRT, they actually stay in treatment, so they like it. But how about the research evidence? Well, we know that the vast majority of published studies are either single case studies or case series. And there are actually 5 published randomized controlled trials. One was published this year, so it's not in my presentation, but there are actually 5 of them. So 4 of them were published in 2013 and 1 was published in 2016. And as far as I know, there's 1 ongoing trial in Paris that is a randomized control trial. But what do these CRT case studies actually tell us, and what do the RCTs tell us? Well, the case studies actually inform us about its feasibility. It is feasible. We can actually do CRT with our patients, and they like it. It is appropriate for individuals of different ages. It is also appropriate during different states of the illness. So patients who are severely ill have received CRT, and patients who are weight recovered have also received CRT. We know that the treatment has always been delivered in conjunction with treatment as usual, and is suitable for delivered individually, in groups, and in families. We can deliver it for outpatients and inpatients, and the material that's been developed, it works really well with this patient group. So what do the RCTs tell us? Well, I had initially planned to go through the 4 randomized control trials in more detail, but as you can see now, I have a few minutes left, so I'm just going to skip through this really quickly. There are 4 of them. So confronting fear using exposure and response prevention for AN, training cognitive flexibility in patients with anorexia, pilot randomized control trial. Is outpatient cognitive remediation therapy feasible to use in randomized clinical trials? And the effectiveness of cognitive remediation therapy in patients with a severe or enduring eating disorders. And we also have the last one called brain effects of computer-assisted cognitive remediation therapy in AN, which is a pilot fMRI study. So there are actually 4 of them. And since I don't have enough time right now, I'm just going to summarize them. What do these 5 randomized control trials tell us? Well, in conclusion, they show us that RCTs in CRT are feasible. They might help reduce attrition. They can improve neuropsychological functioning as assessed through standardized neuropsychological measures. They increase quality of life, and then might be more suitable for those with poor set-shifting abilities at baseline than those scoring within a normal range. However, there are quite a few limitations that we have to take into account when we evaluate these RCTs. So first of all, there are large variations in design. So in the intensity of CRT, the number of sessions, the focus of the tasks that are being given. And there are also variations in how CRT has been delivered. So some have delivered it face-to-face, and others have delivered CRT through computers. And also there are variations in sample characteristics. So some of the patients have been weight restored, others are severely ill. And finally, there are variations in outcome measures. So when researchers have looked at outcomes of CRT, they've looked at attrition, for example, neuropsychological functioning, eating disorder psychopathology, and quality of life. And of course, the sample sizes in these 5 studies are quite small, so they're at risk of being underpowered. And finally, there are actually only adult RCTs, so we don't really know about the effect of CRT in children and adolescents. So to sum up, we're not quite there yet when in terms of saying something about the effect of CRT. And we need additional RCTs in order to establish the effect of CRT. And I think the first steps to take is to increase the sample sizes and to determine how we measure the effect of CRT. So what kind of outcome measures do we want to look at to determine what effect CRT has? If you want to read more about CRT for AN, have a look at this review paper. It was published in 2014 by my supervisor, Professor Eyvindre, and myself. It lists everything that was written up to that point on CRT for AN, and it's freely available in Journal of Eating Disorders. So I would like to say thank you for your attention. I managed to get through all the slides. If there's something that I missed, if there's something that you want to know more about, if you have questions today that are not being addressed, please, drop me an email and let me know what you're thinking of. All right, thank you very much.
Thank you, Camilla. That was really great, and thank you very much for staying within the 30-minute time frame. Very impressive. I think we'll take some questions now.
Okay.
If anybody has any, I believe you can just type the questions in the box. So I wonder, while we're waiting for one, I have a few questions, Caroline. It's so great to see 5 RCTs pop up in the last 5 years on this topic. Could you elaborate a little bit? You mentioned that one of the kind of areas for exploration for next steps is how we measure outcomes. Could you speak a little bit to that? I kind of worried about practice effects myself
Yeah.
when doing these kinds of trials. What could you elaborate on that?
Absolutely, and I think the outcome measures, or the way that we measure outcome, has been an issue, at least since I started working in this field. And I did a feasibility trial, and we used neuropsychological testing, so the standardized neuropsychological tests both before and after CRT. We didn't have a control group, so we couldn't really say anything, about the changes that we saw, if we could say that that was CRT or anything else. But I'm guessing that when you do repeated neuropsychological testing, there will be practice effects. And if you do them, say, for example, in a 10-week period, it's highly likely that your patients will remember what they did 10 weeks ago and perform slightly better. And that goes especially for neuropsychological tasks like the Ray complex figure, for example, which has this aha moment when you first do it. And if you do it again, that aha moment will, be lost. So you will know what the person who's assessing you wants from you. I think, in addition to practice effects, I think it's important to think about what kind of changes we can actually expect after doing a few sessions of CRT. So most studies that I've seen, and the RCTs as well, they do between 10, 15, up to 30 sessions. And are we actually likely to see any changes on a neuropsychological test during such a short time span? That's something that we need to think about. So I also think that we should consider other ways of measuring the effect of CRT, and not just changes in neuropsychological functioning. And I think that some of those outcomes should be, of course, eating disorder psychopathology. We could look at changes in metacognitive awareness, for example. We could look at changes in quality of life. We could look at changes in self-reported flexibility and central coherence, not only in terms of kind of generic measures, but also in terms of eating disorder specific measures.
Right. Yeah, absolutely. The generalizing to the behavior, right, is the crucial piece I think that's missing. So we have a couple more questions. One question is basically, well, it's kind of an admin question. Will you be providing the slides? I'm not sure about that.
Definitely.
Oh, great. That was easy.
Yes.
Much harder question for you. So we have a question from Gillian, who's in a milieu treatment and an inpatient eating disorder unit, and they've used your manual to run weekly CRT groups by herself and with their psychiatrist.
Okay.
But they found that it's quite challenging to do tryouts in an inpatient unit. What are your thoughts on that?
I think I've had this conversation before, and I think the tryouts, as they're listed in our manual, or as homework in Kate's manual, they're not set in stone. So if you're doing tryouts at an inpatient unit, you need to kind of figure out something that is specific to your patients and that they can actually achieve in the unit. And in my experience, patients will sometimes refuse to do their homework or their tryout. And that usually happens because they're not motivated to do it. So my suggestion is to try to find something that the patients want to change themselves. Even if they're inpatients, I'm sure they will find something that they want to try to change. Maybe they want to learn a new skill, or maybe they want to do something completely different in another way, but they can't really kind of figure out how to do it. So use kind of personalized and tailored examples or homeworks for your patients.
Right, that's great advice. I find that when we tailored to people's specific personal lives, they were definitely more likely to do it as well.
Absolutely.
We have a great question here from, apologies, Thorgerder, if I am getting that wrong. But what about, are there any research findings in regards to CRT with other disorders, maybe bulimia nervosa or binge eating disorder?
Not that I know of. Not that I know of at this point. So, in terms of the existing evidence when it comes to CRT and eating disorder, it has been mainly delivered for patients with anorexia nervosa, and I think the case why that is because it's based on your psychological studies in anorexia nervosa. But of course, I wouldn't be surprised if you could use it with binge eating disorders and bulimia as well. And perhaps we can look at, the bulimic disorders as being perhaps too flexible and too little rigid, or being too preoccupied with the bigger picture and not, the fine details. So if anyone wants to discuss, tailoring CRT for other eating disorders, I'm more than interested to discuss this.
Great. Yeah, I know that we did a study where we looked at the neurocognitive profile of adolescents with bulimia nervosa, and we found that there was, for certainly with cognitive remediation, or sorry, with central coherence difficulties, it seemed to be a memory issue, which was
Yeah.
interesting, and because that's really conducive to kind of CRT style cognitive retraining. So that was cool. Another question for you. This is about implementing CRT in a group scenario with teens in a PHP IOP program. This person, Katie, says that she's finding that when they do the activities as a group, there's like a competitive, comparative quality that infiltrates, and it distracts the clients from the process. Any
Yes.
suggestions for keeping the group work focused on the process?
It,
And also a second part of this question is, how do you encourage a group to stay process versus outcome focused, other than the guided questions? She was thinking about giving them a brief explanation of the purpose of CRT, but that may be too much for young teens. What are your thoughts?
So the whole group CRT issues is a very good question, and you will always find this when you work with patients in groups, especially when it comes to playing games and doing tasks. Some of them are going to compete with each other, and especially because a lot of our patients, especially with anorexia nervosa, are perfectionists. So my advice to those of you who plan to do CRT with groups or who are currently doing CRT with groups is to, during each and every session, or even during or before each and every task, talk to your patients about the aim of CRT. So talk to your patients about the aim of identifying thinking processes and the goal of a kind of becoming more aware of how you think. So the goal is not to become really good at the tasks that you're doing, or do it really quickly, or do it better than anyone else. The goal is for each and every one of the patients to become more aware of their thinking styles. And I think, I've worked mainly individually with my patients, but I keep telling them every time I meet them, all right, remember now, the goal is not for you to finish this task. I want you to tell me what you're thinking while you're doing this, and try to reflect on your thinking styles. So I think that's something that you need to kind of do over and over and over again, kind of reminding your patients about the goal of CRT. And for the second part of that question, I think it's a really good idea to kind of to talk to your patients before they start doing CRT what the aim of the treatment is. I think it will make it a lot, easier for them to understand the purpose behind CRT, and as I talked about earlier, why the content of what they're thinking is not so important.
Right, that's great. Okay, so we have a question from Lisa. She wants to know, how effective could CRT be with a young adult with sort of bulimic spectrum AN anorexia who is also has comorbid Asperger's or and a non-verbal learning disability.
Oh,
What are your thoughts?
it's a tricky question. I don't have any experience with that particular kind of comorbidity. Um, I think in terms of the Asperger's, I think it would be a really good idea to try CRT out and see if the patient can start reflecting on some of, the rigid thinking styles or behaviors. Since CRT is developed for anorexia nervosa, and that's kind of where all the neuropsych evidence lies. I'm not gonna, I can't oversell it, but I would definitely suggest that you try it out and try it out very easily. Bring some of the games, some of the tasks, sit down with your patient, and just talk about thinking styles and see if your patient likes it. And when it comes to an effect, I mean, again, as I mentioned, quite late in my presentation, the effect of CRT, in order to kind of figure that out, you need to do big randomized controlled trials. And also you need to kind of figure out what kind of effect are you looking for. Are you in that particular patient, are we looking at a patient who could increase awareness? Definitely, definitely. In changes in your psychological functioning? Maybe. Perhaps being able to kind of better reflect on everyday thinking strategies? Absolutely. So I think give it a go and see if your patient likes this and find it useful.
Great, thanks. Caitlin asks, any thoughts on using CRT with adults with bulimia or binge eating disorder?
As I said earlier, give it a go. I'm not sure that you are, well, since the tasks are specifically, developed for AN, you might have to tweak them a little bit with patients with other eating disorders. But if you look at patients with bulimia, for example, I'm sure you can use some of the tasks in the same way that you use them with patients with anorexia nervosa. But kind of look at tweaking them a little bit and look at the tryouts, for example. You might have to look at set shifting or cognitive flexibility in a different way than what you do in anorexia nervosa.
Okay. Okay. Yes, Lisa just clarifying. I have a bit of a clarification on the diagnosis that it was anorexia binge purge subtype. Yeah, that's what I thought. Yeah, it's very interesting, isn't it? That I think the data are just pretty strong that to indicate that there are anomalous neurocognitive inefficiencies in the anorexic population, and I just don't know that there have been sufficient studies on the bulimia nervosa or binge eating disorders to be able to really design a CRT intervention around it yet. But that's not to say it's not going to be useful.
And I mean, we are currently, or I'm involved in a study in Australia right now who have done CRT for obesity.
Right.
And so the thing is, I don't think you can use the exact same manual, because the manuals that exist today, they were developed for anorexia nervosa, and anorexia is very specific in terms of the eating disorder psychopathology. But I do think, tweaking it a little bit as they've done for obesity, it can definitely, be useful.
Right. So that's interesting. What are your thoughts, Camilla? I sometimes, with specific patients, might suggest that they look at some of these brain training apps as kind of practice in between sessions. What are your thoughts about that, like Lumosity, or I know there's several other brain training apps now available?
Yeah, I think that's...
By the way, just full disclosure, I have no financial relationships with any of these companies.
No, me neither. As I said, we're using a lot of the board games from a specific company who's kind of donated a lot of the games that I've been working with. And I know that there are a lot of apps that you can download to your phone and that you can use. And I encourage it. So I've actually had a few patients come to me and showed me these apps that they're using that are identical to the board games that we've been using in treatment. And I think it's a really good idea. I think we have to remember that a pivotal part of CRT is the reflection part. So thinking about thinking and actually having someone asking you, what are you thinking right now? What strategy are you using? Could you do this differently? What are the pros and cons of the way that you're doing this right now? So even if I do encourage using these apps, I think it's really important that if you if you ask your patients to do it, when your patients come back to therapy, talk about it and talk about their strategy so that they don't just, get hooked on some app and you continue doing it without the metacognitive process in it.
Right, so it sounds like what you're doing is using CRT as a starting point, as a tool for a discussion and reflection process with your patient, rather than it being the be all and end all, like final intervention.
Yeah, absolutely. So what I want with CRT for my patients is for them to kind of start reflecting on how they think. And I mean, we can call it, we can call our patients rigid or that they lack in central coherence, but it might actually just be a cognitive bias. So they might actually, have learned to think in a certain way through their whole life, as most of us have. So
Mhm.
to become aware of how we think, that is the first step. And I mean, they our patients don't necessarily need to change, their whole way of thinking. So we need to kind of help them to identify thinking styles in certain situations which are not working properly. And we do that through the games. So the games are more like means to an end, and we use these to kind of to have something to talk about. So the strategies in the game, they kind of they let us talk about strategies in real life and relate, in session thinking without out of session thinking.
Okay. So at what point in treatment is it most effective to introduce CRT?
There has been no randomized control trials, I think, exploring this. CRT was originally developed as a pre-treatment, and Kate and her colleagues at King's College, they delivered CRT to an adult patient who was called at that time treatment resistant. So this patient had been in and out of several different treatments, and she didn't want to participate in any of them. So they started, offering her CRT as a way into treatment and as an easier type of treatment, which, would to realize that she was able to change or to motivate her to change. So when I look at CRT or when I think about CRT, I think you can use it at different points, like for a patient. So you can use it as a pre-treatment if you have a patient who's either on a waiting list perhaps, or for a patient that doesn't seem to want to engage or be able to engage in other forms of treatments. And then you can see CRT is being delivered to severely ill patients. I've had some severely ill patients having had CRT, and that's worked really fine. And then there's CRT, being delivered to weight recovered patients who still struggle with these typical thoughts and behaviors with rigidity and the preoccupation with details. So I think it could be suitable at different times for different patients. So you'll have to figure out what your patient needs.
Okay, great. Um, well, so anything else that we didn't ask you, Camilla? Anything that we've forgotten that you'd like to mention at this point? Perhaps you could let us know what you think. What's the future of CRT?
Yes, I think I think CRT has a bright future. I think CRT needs a little bit of revision, if I can say that. So as I told in one of my last slides, the way forward is to do more randomized control trials. But until, before we do that, I think we need to, you know, kind of figure out what is it with CRT that we expect will change in our patients. So are we doing CRT with our patients because we want them to perform better on a neuropsychological test? Are we doing CRT to increase our patients' awareness of how we think, and somehow that will help them in treatment as usual? Or do we want to increase their motivation to change? So I think the people and kind of on a global level need to figure out together what CRT actually contributes with. And the fact is that our patients really like it and they find it really useful. And all the clinicians that I've ever worked with or ever talked to, they find it the same and they like to work with it as well. So there's something in CRT. I think at this point, we're not really sure what that it is. So I think we need to figure out that.
Okay. Dr. Linval, I don't know that there are any other questions, and so I think we might wrap up there, unless anybody wants to slip in a sneaky question at the end. Thank you very much for giving us your time and expertise. I'm really excited to see where CRT might go. And yeah, it was an extraordinarily fun treatment to do as a clinician. I absolutely loved it. Just to add to the other point of the last person who asked the question, we obviously in our trial at Stanford, we did it as a pre-treatment, and that before CBT, and that seemed to enhance treatment retention and definitely significantly reduced attrition. So it was great because it's very it really helps to form that clinical bond and a really solid working relationship with the patient before you actually get into putting pressure on things like weight gain and shape and weight, as you pointed out. Yeah, Camilla, thank you very much for your time. This was really enlightening.
Yeah, and thank you to everyone who listened in. And of course, if you want to get in touch with me, just use my email address, which is on the screen right now, I think, still. And I'm also supervising clinicians all over the world. So if you are a team somewhere that want to start implementing CRT, let me know if you need supervision or if you like a workshop or anything of that sort. I'm available for that.
Okay, great. All right. Thank you very much, everyone.
Bye.